first doctor's office experience, you remember, was probably a vaccination. It hurt. The doctor was a bad guy. Much as we physicians don't like the idea, the truth is that most of your visits to a physician's office involve negative feelings. Something hurts. Something that doesn't hurt can turn out to be really dangerous. Those feelings are reasonable. There's nothing we can do about them. We feel the same way. Just like you, we are scared when something goes wrong with our bodies. But some negative aspects of the physician experience can be improved. Long waits, uncomfortable exams, unreasonably expensive medications, unpleasant side effects, and post-operative pain. We are aware of these and we're doing our best to resolve them. But we're often dealing with a healthcare bureaucracy that sees the trade-off between your discomfort and their very real financial limits very differently than you do and we do. There's a constant jousting over patient needs between doctors and financial administrators. And by the way, healthcare in America is pretty damn good because doctors win many of these battles. One reason your doctor can treat that funny feeling in your chest is that he views the problem with a much broader perspective than you do. Years of study have taught him how your internal systems work. Years of experience have taught him how your physical environment, lifestyle, and medical history affects those systems. Medical tests then clarify what's going on in there. And constant interaction with the business infrastructure of medicine tells him what's realistically available to help you. The intent of doctors, hospitals, and clinics, and the medical process is to relieve pain, cure disease, fight degeneration, and prevent premature death. I believe there's an obvious but largely ignored strategy to help both the process and the outcomes. And that's why I'm up here today. I got the idea from Sam. For years, Sam's angina was treated with drugs and eventually stents to prop open his coronary arteries. Sam was older, hypertensive, hyperlipidemic, and diabetic. His chart looked like many of those seen in a cardiologist's office. The frequent flyers on first-name basis with the receptionist. But Sam was a tough, serious, self-made man. He thought about his problems, why they happened to him, and what we could do about them. But most importantly, Sam took responsibility for improving things. He dove into my lifestyle advice, slowly built up an exercise regimen, worked with a nutritionist. Sam asked questions, made assumptions, and made changes to his daily regimen. He then correlated that with a detailed log, with things that he could measure at home, like his heart rate, blood pressure, glucose, and the things we could measure for him in the office, like lipid levels and homocysteine levels, hemoglobin A1C, and the like. And it worked. Sam is no longer hypertensive. He's no longer diabetic. His lipid levels are so low that he's now off statins. He's had no angina for 6 years, and his myocardial perfusion studies have completely normalized. See, Sam couldn't change his genetics, but he could change his behavior to greatly improve his heart health and his life. He used the scientific method we all learned in high school to solve a complicated problem. Sam formulated a hypothesis, made a plan, acted on it, observed the results, and then revised the plan based on what he learned. Sam could quantify his health better than any doctor because he was and still is living in that body. That's one hell of an advantage over me reading his test panels or interpreting his scans. I propose that physicians teach patients to apply the scientific methods to the pathology that drives them to the office and to their healthcare in general. Two things that are closely linked. Sound obvious? It is. and it's a growing part of my medical practice. But up to now, it took a very special person like Sam to do it well. Now, I don't blame the less than Sam patients. There aren't that many guys like Sam out there. Each patient would need to be taught Sam's method and then provided the tools to make it easy to apply in his own life. And that recently became quite a bit easier. A simple, powerful, and economic tool has popped up right in front of our eyes. But us healthcare guys are so bound up in our shopkeeping, you know, the doctor, hospital, insurer, government loop, that we rarely look up to see what's going on in the greater world around us. Consumers and businesses alike are happily surfing on exhilarating waves of creative disruption. Amazing technologies allow us to listen to music without those spinning plastic discs, see an event where and when we want, attend college at home, and take pictures with electrons, shop without driving. Creative disruption? Suppose the healthcare system combines the remarkable and inexpensive smartphone-connected sensors that are cascading onto the market now, with the miraculous power of the internet and the tools of big data to transform the less than Sam patient into Super Sam. But why big data? In cardiology, the gold standard for healthcare monitoring is the Framingham study. Health monitoring of roughly 5,000 residents of Framingham, Massachusetts. Not every doctor agrees with Framingham in detail, but few would argue that it hasn't been valuable in understanding important parameters like blood pressure and cholesterol in various populations at various ages. If we can derive such guidelines based on studying 5,000 people, imagine what applying big data analytical tools to 1 million continuing person sensor-driven data streams could reveal. And because nearly all the cost of these clinical studies is generated lies in generating the data, and that cost is paid by individual sensor users, a big data clinical study that dwarfs Framingham could be close to free. I propose that physician visits related to systemic disease, that is, the lifestyle diseases that affect so many Americans, like the ones Sam had, include decisions made on the basis of what the sensors tell us about their daily regimens. And that the potency of these decisions is amplified by what you and your doctor can learn about what 1 million sensors are telling us about the health effects of various regimens on 1 million other bodies. I call that self-quantification, or self-quant for short. Quantification because measurement connects cause and effect. Self because connecting cause and effect empowers you to improve your health. Self-quantification can improve the health of Americans young and old, upgrade medical outcomes, and materially reduce the cost of healthcare in our country. Good technologies move fast. Someday soon, maybe self-quant apps will be nearly as common on cell phones as selfie apps or Angry Birds. And with my apologies to Steve Jobs, there is just one more thing. Today's healthcare is physician-centric, with our training, our expertise, and our interface system, that is, our office. We are the logical hub. It works, but a peek inside this accidental structure reveals a disorderly history of patches and extensions made to keep up with changes in demographics, technology, money flows, and social evolution. American healthcare, physician-centric healthcare, is what a software engineer would term a legacy system. A similar situation afflicted American banks as they struggled to accommodate changes in the nature of money. Until 1960, money was purely physical, paper or metal in one form or the other. Then computers turned money into informations, electron that moving along wire or stored as magnetic traces on disks and tapes. Your bank's back office, okay, that's their quaint term for their computer system, had to add layer upon layer of software just to keep up. That patchwork back office worked, but it didn't work well. It was a legacy system, just as the American healthcare is today. Banks solved the problem by replacing that creaking, clanking, steam-powered contraption out back with sleek, new integrated software, thereby making A. Perot, whose Electronic Data Systems Corporation bet the farm on building a new from scratch back office system, one of the richest men in the world. Great ideas have enormous energy. Over a few short years, banking became transaction processing. Electrons flow from the bank to the employer, to the employee, to the supermarket, and back to the bank again. It was fast, efficient, and reliable, and it triggered an avalanche of innovations like ATMs and e-commerce. Our legacy healthcare system is a lot like banking in the 1960s. It works, but it's in desperate need of disruptive change, like the shift from wads of paper to transaction processing. Self-quant is patient-centric medicine. A physician is involved, but the patient himself is the hub of self-quantitative care. Self-quant is the first footprint of an iron giant. Like transaction processing, patient-centric medicine is deeply disruptive care. Imagining a patient-centric healthcare system, you'll find yourself navigating a sleek, new healthcare landscape. Think about it.